You're listening to Teets and Ash, the show where two real-life providers get real about health habits, wellness, and the broken healthcare system. We're here to educate, empower, and entertain you. One appointment-free episode at a time. This is healthcare without the bullshit.
Hey, you guys, Teets and Ash. We are talking about direct primary care today. I know that we touch on it quite a bit, but it really is the future of healthcare. So
It definitely is.
what is direct primary care? So basically, it is the same as any other primary care. It's just we have taken out insurance, taken out the middlemen. So it's more cost effective for you and for us. It takes less staff to run a non-insurance based clinic. So we pass along that savings to you guys.
It's interesting we call insurance the middleman when they're no longer the middleman.
They're the men.
They are the men. They are the ones that run it.
They're the
own
ones that
it.
are deciding how we practice primary care. They're the ones who say, yes, you can have this. No, you can't have this. We would like you to do this before you can do this. And you have to ask permission.
So that we used to ask them to cover, and now they're like, oh, I love your suggestions, but no.
But
And
no.
I want you to do this, this, and this, even though the people that are giving you this information may not be like the same level of education
Mm-mm.
that you are.
No, they're actually filling in boxes. They're just checking a box.
Absolutely.
Oh, you don't meet this criteria. You don't fit in that box. So nope, we can't approve that.
Right.
They don't take into mind that you know the patient, that you know their background, their socioeconomic status, you know, everything that's going on in their lives, the foundation of their health. They don't know that you know that. They don't know that. They don't care. You just didn't click their box.
After you have 3 or 4 detailed conversations
Oh,
and
God.
have sent the paperwork 73 times,
I sent it 7-11 times the other day.
they will then be like, oh, you know what? Maybe you're right. Or they're just going to dig in. They're like, no.
Ooh, I had one throw an anchor the other day. I think I sent over the same PA with the same information
Yes.
11 times. And each time, Annie actually talked to one of the advocates for the patient. And she said, can you just send it one more time? I said, it's the same thing that I've sent time and again. Nothing has changed. She meets criteria. All of your criteria that you want her to meet, she meets. And yet y'all aren't reading what I'm sending. So help me out here. Send it again. Got denied. Just started a new PA just to see what would happen. Approved. Because in my PA that I attached my information to, I said, this is the 5th or 6th time I've sent this over and you have denied it. And patient meets all criteria. So I just put that in the letter and they figured it out. So yeah, approved. So here again, direct primary care. We do not utilize your insurance for your office visits. You pay a flat fee every single month, depending on age. You pay the flat fee. You get unlimited visits. You can absolutely use your insurance for medications, x-rays, labs, whatever, but we can actually get those to you a lot cheaper too.
What if I
But-
need to see an orthopedist?
Oh, we can refer you out. And we
Can
have
I use
coordinated all
my
of that.
insurance?
You can
at the
absolutely use your
orthopedic?
insurance. Mhm. If you want to, absolutely you can, but you'll still find us cheaper.
And as Ashley always says, you do not use your car insurance to take care of the tires, the windshield wiper fluid,
There's windshield wiper fluid. Oh yeah, yeah, not
that's blinker fluid.
blinker fluid.
God. And so why would you use it for primary care? Like you don't need to utilize. It's
No.
really cost effective. I mean, everybody it's offered, through their insurance policies.
Yeah.
But if you're really utilizing your insurance effectively, it wouldn't really be used for you to
Windshield wiper.
to purchase blinker fluid.
Perfect. So
She's so pretty.
anyway, am I turning red? I think I'm gonna be. So, and we do have people from all walks of life in our direct primary care practice. We have students, we have single moms, we have multi-million-dollar business owners, we have patients. They
Mhm.
just we don't take Medicare either, just because we want to make it as economical as possible. And it actually is a lot more economical for patients to utilize our services because you do get access to your provider 24/7 with urgent care issues. A lot of times you can leave here with a prescription in hand because we have an in-house antibiotic pharmacy. We can get discounts on x-rays, labs. We can refer you out if we need to. I mean, we do everything that a primary can do. Our main job is to keep you out of ERs too. We are ER trained. We worked in ERs forever. And we saw a lot of patients coming into ERs who couldn't get into their primary because they were backed up and booked up. So there was a recent survey done where they asked ER providers how many of your patients are actually ER patients. And they said anywhere from 15 to 25% of all ER patients are actual ER patients. The rest are usually in primary care. So here we are running down these patients as quick as we can in the ER because it's all about metrics and time. They don't care if you're dying. Providers do, the metric people. Yeah, C-suite people. So, we're running these people down because they can't get into their primary, because primaries are driven by insurance. You have to see a patient every 10 to 15 minutes. And realistically, it's 7 minutes per patient, 2 minutes for the patient to talk, 2 minutes for the provider to talk, and about 3 to 4 minutes for you to document, make sure all of your charting is done, make sure that your ICD-10 and CPT codes are correct so that you can get reimbursed for very little.
Did you drink a Red Bull before you got here?
I did not have nothing. Am I talking too fast?
Poquito.
So
You are on it today.
I got that
She's
box
passionate
and I
about
jumped on
primary care.
because I got tired of seeing these people come to the ER and racking up these crazy, insane medical bills for a primary care issue because they called their primary and they couldn't get in.
Absolutely. And that is another big part of it. When you call your primary care's office, and I mean, when's the last time you've actually been seen because your throat was hurting terribly, or your ear was hurting, and you're just like, I just want to be seen. I don't feel good. They're like, okay, we'll see you in 7 weeks. And you're like, oh, wow.
Or you can go to the ER.
Or you can go to the ER. You can go to the ER.
It's a lot of you can go to the ER. I
And
can't
why
tell you
don't
how
they
many
say
patients.
urgent care?
Yeah. They don't say urgent care.
They say ER, don't they?
They do.
I don't know where that fallout lies.
I don't either.
I think I think that's less provider related, but I have my own theories. But we do. I mean, you see a lot of cough, cold, congestion, ear pain. I threw up 3 times.
I had nausea once.
Or my family was vomiting and now I'm nauseated, but I'm afraid. Naked and afraid.
Naked and afraid, hugging a toilet.
So, therefore, those are things that you can be seen by your primary, at least in a direct primary care state. We can see that as the day that you're sick. We keep a panel low, we keep it small so that we have time to make add-ons for patients that are ill.
Absolutely. So, to be financially successful in an insurance-based clinic, that panel has to be 2,000 patients or more. And do you think that your provider is going to know all the ins and outs of your life? Do you think you have a really good relationship and rapport with your provider? Maybe, maybe not, but that's really difficult to know your patients really well when you have that large a panel.
Right. And you're only allotted 15 minutes max. And then, what happens when you're talking to your provider? You go in and you're literally there for a medication refill because they told you, hey, you got to come in. We haven't seen you in 6 months. You go in, and they're like, so how's everything going? And then yesterday or 2 days ago or whatnot, that changes the entire visit. And if they are decent humans, they're not just like,
oh yeah, that's another thing.
Oh, really? That's super horrible.
Oh, I'm so sorry. Would you like some
Usually,
that? Just a little bit. Okay, great.
They will stop, and then that will totally alter their entire day, hopefully positively and alter your day. But for the most part, now everybody else behind you is backed up because everyone is slotted timeframes that are so tight that it doesn't allow for wiggle room.
And you cannot have a secondary issue. If you're coming in with an earache and you say, by the way, my left great toe has an ingrown toenail and fungus. Okay, we'll have to schedule you an appointment for that. We can't talk about that at this visit because the way that insurance dictates how they bill and provide care, they can only have one complaint, one per visit, and they can only bill that out the one time. So in order for that provider to get paid correctly and adequately to run their practice, they have to have you come in for another visit.
So that's something else. It's something we should talk about. Like, people think you're just like Scrooge McDuck, like swimming in the money.
Capacity.
Yeah, right. Well, and even if it across the board, neurosurgeons maybe, but their billing is significant because their procedures are significant.
Yeah.
But in a primary care aspect, there are no primary care providers that I'm aware of that are just
rolling in it. Absolutely not.
And the fact that patients truly believe that you're just like, oh, you're going to charge me for that, you're going to charge me for that. So DPCs can get, and like a money grab, like nickel and diming. So kind of go through that. Talk about that. How it's not a nickel and we're not trying to nickel and dime patients. So we're very upfront with
absolutely.
This is going to be out of pocket pay for you. Very few things are out of pocket here. It's usually included. There's a couple things like you could come in and want some random lab.
It costs us
what it costs us.
Yeah, I can't just sit here and say, yeah, I'm going to eat the cost of that $110 panel.
Yeah,
it costs me $110. Well, it's going to cost you $110 as a primary care patient. I'm not going to upcharge the crap out of you either.
Right. Yeah.
We are not going to upcharge them.
There's no reason to upcharge,
No.
but there are additional fees, but that usually is we go over that. And maybe
We say it ahead of time. I'm not going to surprise you with surprise billing like you get a lot of times with
Right.
insurance as well.
but I think there's a part where patients just they're not familiar with DPC. And
They're
they're
not even
used
familiar with their
to
own insurance.
100% because they don't understand how their insurance works. I mean, I'm not gonna lie. I didn't really understand how my insurance worked.
Well, working in
When
healthcare
you-
for 30 years, we didn't know how
No.
insurance works.
No.
Even
Not
as
at all.
providers, we didn't know how insurance worked. I
Right.
knew that I had a $5,000 deductible and I paid $1,400 a month and a $200 copay to go in an ER and a $50 copay to go to see my primary and a $75 copay to go see my specialist. And I was like, my God, I'm spending all this money. And come to find out, to see my dermatologist was $65. But if I used my insurance, I had to pay $75 on top of my $1,400 a month insurance. It was like, what am I doing?
Which every insurance is different.
Yeah,
So
they're all
some are going to pay more, some are going to pay less.
And if you've got a great plan that you're locked into and grandfathered in, oh my God, keep it.
It doesn't mean you're going to be able to see your provider
That's true.
anymore. So that's where, once again, it comes into doing a direct primary care where you can get in, you can talk to them, you can enroll your family, you can, we can see children that have an
Mhm.
earache because
Absolutely.
their mother is a patient and they're a patient. We can see mom because she has a cough. That's not, and she didn't get better as quickly as her children
Mhm.
did. Those are all things that people just want to be taken care of. And especially after like pandemic and everything.
Yeah, you want to have a really good collaborative relationship with your provider so that they know who you are, how your family is, what y'all are
Mhm.
going through, because all of that factors in how we're going to care for you, truly.
Mm.
And, a lot of times in primary care, it's very reactionary. The system is reactionary.
Oh yeah. What does that say? When is the
When was the last time you got
right in?
seen and got sick and got right in to see your
Man, I wish we
provider?
could just do a poll on this, like in the comments. Just a question for the general population. You woke up on a Thursday morning with fever and a sore throat, and you called your primary doctor to get you in. That's what I want to know. And I want to know, like,
And let's be honest here too, because
were they able
you
to
cannot
get
sit
you
there
in
and tell me
in 24 hours?
you can't sit there and tell me that you saw your provider that very same day and people sit
Without
booked up for
an
months in
already
advance.
established appointment for medication refills.
Not only that, but because if 75% of the population is coming to an ER for a primary care issue,
Right. Absolutely.
we're seeing them. I'm not seeing them anymore because I'm no longer in the ER.
So yeah, you see them and in the emergency room, you do ask things like, so when you talk to your primary care doctor, what did they say? And they're like, oh, I can't get in for 6 weeks. And you're like, and you kind of ask that leading question because I want to know, one, did you talk to your doc? Did you call their office? What's their plan? When you tell me, oh, they said they'd make me an appointment in 6 weeks. Well, that hurts me for you because I get it. It is, makes you feel.
And not only that, but we have a lot of patients that come to the ER that don't have any insurance whatsoever. And so they said, well, I could have gone to the urgent care, but they cost $200 up front. And the ER, you don't ask me for any money up front. And they don't. A lot of people,
they do.
they do, but they don't because a lot of
you
the time they will say, if you'll give us, a little bit today, we'll knock off 95% of your bill. And that's at a for-profit facility. Talk to you about that soapbox all day long because that's how I figured out we need to do direct primary care because, okay, I'll just tell you. I have the receipts.
You twisted my arm.
You twisted it and broke it. So my daughter broke her radius and ulna back in 2022. I took her to the ER. I didn't have insurance. I was paying $1,400 a month for my insurance. I had a $5,000 deductible, $10,000 max out of pocket for family. My ER copay was $200 if I had insurance. So I go to the ER that I'd worked in, saw the provider, sent upstairs, had seen the pediatric orthopedist specialist the next day, had surgery the next day, pre-op, OR, PACU, anesthesia, back to the room, discharged that night, and was sent home with a $63,000 bill. I said, oh my God, that's the insurance-based price. I'm like, y'all are crazy. Send me the cash-based price. Well, do you qualify for Medicaid? I said, no, I'm a business owner. I do not qualify for Medicaid. They sent it to me anyway. We filled it out. Of course, you don't qualify for Medicaid. Then they sent me the cash price bill, which was $5,400 for the entirety of her stay. Our pre-op, PACU, anesthesia, all of the medications, all of the x-rays, the room and board, all of it, $5,400. And then because I did carry a small AFLAC policy, like a catastrophic policy, I pay $300 and change a month for that little Aflac policy, but they gave me $1,800 towards that visit in patient stay, and it cost me $3,600. Now, had I been paying $1,400 a month with insurance and then the 10,000 max out of pocket family deductible, you have the 80/20 that you're responsible for too. So in essence, I got away with a whole entire surgery, day and a half stay, ER visit, or pre-op PACU anesthesia for $3,600.
So there, I mean, that's proof's in the pudding.
Yeah. And if you go to any of your provider's offices, ask them how much a cash pay visit is, and they'll tell you. And a lot of times they'll give you a discount on top of that.
However, some of the states are changing laws where
California, you have to use
use
your insurance.
insurance.
Yeah. I'm sure you may have seen the guy who had an ambulance ride for his daughter who had a seizure. He needed the ambulance ride to the hospital, and they ended up charging him. It was $800 for the ambulance ride. And he says, "Oh, I don't think y'all got my insurance. And so let me send you my insurance." So they sent the insurance over and ended up being $1,600. He's like, "Wait a minute. Why is it more? It should be less because you use my insurance." Like, no, it goes to your deductible.
And
they have to use it.
that's a heavy hit when
Huge.
you are already, financially strained.
All of America
It's
is financially strained.
super emergent
Yeah.
and truly emergent issues, and then you get hit with a big bill just in the front. Like
It just makes you feel defeated.
It does.
I hate it.
It does. I mean, that's part of the machine.
I hate the machine right now. Well, I hate the machine, period. Not right now, just at all. Just because the way that it's changed since, I think the late 90s,
Back in
mid to
my
late,
day,
back in the 90s,
in the
mid to late
1900s.
Everything changed. Everything became business-based. I remember the hospital that I worked in was run by a bunch of nuns and priests. It was great. We had the best, staffing, and we were treated amazingly well. And then
Pop your knuckles if you charted
they
off.
did not. They locked the bathroom on you. You couldn't go to the bathroom. I'm just kidding. They did. But we had this businessman come in, and a lot of physicians called him the little Irishman. He came in and decided he made it a business model, and that is when everything went to pot. Everything was cut. Everything.
Even the nuns.
Even the nuns were
They
cut. They were
free.
Bye, y'all. The priest, we had one priest left.
That's
Back to
not-
direct primary care. Again, no, it is not a money grab. No. When we say, if you're like 45 to 64 and it's $75 a month, that covers unlimited visits. We have the after hours urgent care line. You
Lab
can have same day or
draws.
next day appointments. It covers your annual lab draw. But yeah, I mean, that money, that little bit of money that you pay out a month, helps keep our lights on. Allows us to pay our staff and our rent, and
It helps us argue with insurance companies
God, it
so that
helps
you
us argue
could
with
get
insurance
your
companies.
medications filled.
Yeah, that phone bill's high.
What do you spend? I bet we spend a real big portion of the day just
I come up here on
talking
Saturdays and do
to
PAs
insurance
and doing
companies.
peer-to-peers. They're available on Saturdays. You know that?
I did not.
They sure are. They're available on Saturdays too.
When you do a peer-to-peer, do they actually let you talk to a doc or an
I don't know who
NP?
I'm talking to. They won't tell me.
Interesting.
It may be a pharmacist. I know I talked to a pharmacist once, and he
Mm.
was making medical decisions for a patient.
I mean, they have some.
Yeah, I get that. I have all respect in the world for I love pharmacists.
Yeah.
They help me so much.
Yeah, 100%.
But when it comes to the line of care for a patient,
Yeah.
there's a reason why. I don't have to run it down. Like, for instance, another patient came in. She's new to me, type 2 diabetic. But she's been on metformin 1,000 milligrams twice a day. I said, "Oh my gosh, her hemoglobin A1C was still 8.4. I said, let's, work on getting you some Mounjaro just because you have great insurance and they should be able to cover it." Well, her insurance came back and said, no. She's going to have to do Jardiance first. And I'm like, I don't like Jardiance. She's perimenopausal. Her GU microbiome's all altered. She's, already had a couple of UTIs just because of her old pH changes in her perimenopausal state. Well, Jardiance, pushes more glucose out of the kidney into the bladder, so you're urinating out more glucose. This is my train of thought, what I'm thinking, and he's just got a box he's got to check. So I'm thinking, okay, we're spilling more glucose in the bladder, we're going to cause irritation, we're going to have another UTI. And Jardiance is a black box warning for Fournier's gangrene. So you want me to try this drug, maybe have her fail, maybe get a bunch of UTIs, maybe even get Fournier's gangrene before you'll even approach Mounjaro, which we know has amazing cardiovascular benefits.
Doesn't dump glucose.
Doesn't dump glucose. It doesn't drop your sugar out. Actually, it works on the B islet cells of the pancreas to make them work more efficiently so that you're utilizing your insurance and your glucose at a more efficient rate.
Insurance?
Insulin and your glucose. Yeah, you're utilizing your insurance more better.
With your
With
pancreas.
with your pancreas, your B islet cells of your pancreas. So yeah. whoo, I got insurance on the brain today.
She's been arguing.
I want my patients to have what they deserve.
Well, or access.
Just give it to them. So find a direct primary care near you. Come see us at the Ashley
Definitely.
Clinic. They're popping up all over. A lot of physicians are transitioning over to a direct primary care practice because they are so sick and tired of insurance dictating how we take care of people, how much they're going to reimburse us for. So, for instance, if you have and you charge $150 a visit, there is an insurance out there that will reimburse you $32 for that visit. And another reason why you have to see a patient every 15, 20 minutes, because you have to be able to pay your staff, pay your rent, pay your electricity. And you don't want your primary care providers thinking about those things. You don't want them to sit in the back going, oh my God, how am I going to pay rent this month? How am I going to pay my staff this month? You don't want them thinking about those things. You want them focusing on your health and keeping you well and keeping you out of the ER. You don't want them focusing on the business aspect.
Well, I mean, if you just if you're only getting reimbursed $32 a patient, think of how many patients that person has to see to
and how will keep
the lights on.
Yeah.
So once you're getting over, 15 patients in an 8-hour day,
it's not even an 8-hour day. Let's be honest.
Well, that you're billing for.
Mm-hmm.
Once you're getting over 15, like you are no longer you're no longer invested in each patient. Like you are literally just
going through
turning and burning. And that's why they are like this the whole time.
And you feel bad because they're not talking to you. You're like, why is my provider not talking to me?
Because
in a computer. Because they can't.
Right. Now, I will say, like, if we're doing this DPC, like sometimes I'm like, let me make one note here because I'll forget. But I do, I make a conscious effort to make eye contact.
Absolutely.
And sit next to them and trying just to talk to them about what's bringing them in.
It's multifactorial. It's not just one or two
is.
things. It's a couple of things. And we can fix it all while they're here. But yeah, that's that. Find a DPC near you.
Find a DPC.
It's the way of the future. It really is the way of the future of healthcare, especially with everybody getting disgusted with insurance.
You'll really be happy.
Just use your insurance what it's supposed to be used for.
Actually, they're changing the laws, right? They're going to allow. They're going to be covering.
Yeah, they're allowing if you have.
At least in Florida, right?
Or is it national? That's what I heard. So they're allowing you, if you have an HSA account, a health savings account that you contribute to, you are allowed to use those health savings dollars towards a DPC membership. You get a high deductible policy, which is going to lower your overall premium. You add an HSA to it, and you're going to come out ahead. You're going to save hundreds, if not thousands of dollars.
HSAs are tax-free.
Yeah, they are.
Helps you on the back end.
Yeah. Okay. So, yeah,
that's what I know.
That's what we know about DPC. Let us know if you have any questions. Send us an email. Shoot us little comments. We'll answer everything.
You're listening to Teets and Ash, the show where two real-life providers get real about health habits, wellness, and the broken healthcare system. We're here to educate, empower, and entertain you. One appointment-free episode at a time. This is healthcare without the bullshit.